Hello to all of our viewers around the world. Welcome. I am Dr. Camran Nezhat, the founder of Worldwide Endomarch. I welcome you to our next series of educational teachings of Worldwide Endomarch and Endo Explained. We thank all of you for your participation and for your interest in endometriosis. Every one of you around the world who has endometriosis, one of her members of her family has endometriosis, or has an interest in endometriosis, has been instrumental in raising awareness about endometriosis towards our goal to find a treatment for endometriosis and end the dynasty of endometriosis and its holding over the patient with endometriosis everywhere in the world. We thank you. Because of your participation, there are many sessions of teachings about diet, about endometriosis and infertility, about endometriosis and pain, back pain, leg pain, bowel, bladder, ureter, diaphragm, liver, etc., that you can go to endomarch.org and look at the webinars and find sessions about endometriosis of your interest. Also, Worldwide Endomarch and Endomarch is proud to let you know we have developed an app called Nezhat Endometriosis Advisor, that it is free and it is donated to all the patients who may have endometriosis around the world. If you go to endomarch.org and look at Nezhat Endometriosis Advisor, can help you to find out if you have endometriosis, if you have pain, or if you are trying to get pregnant, you are not getting pregnant. You can look at that app, which could help you and direct you to see the proper physician. Also, we'd like to thank you for your interest of letting us know what you like to hear, and we are putting these sessions for you. The session today is about endometriosis and ovaries, chocolate cysts, endometriosis cysts, or endometriosis hemorrhagic cysts. As you know, for the best surgical treatment of endometriosis, usually it's better to do a wide excision, means remove the endometriosis as much as possible when it is very safe without damaging the adjacent organs. That is very important, that we remove endometriosis very thoroughly without causing any harm to the organs we are adjacent to the endometriosis lesion. One area that this wide excision and removal of the endometriosis could not always be good and actually sometimes could be bad is ovaries. Treatment and removing of wide excision of endometriosis of the ovaries, especially in younger patients who want to have children, or patients who do not want their ovarian function be compromised, the wide excision could be a very bad idea. And today we have a guest speaker and his guest. The session is being led by the world-renowned GYN oncologist and endometriosis specialist, who is also a professor at Cornell and NYU, and happened to be my brother, Dr. Farr Nezhat in Manhattan. He is going to lead the session with his guest and address this important issue. We thank you very much for your participation, and we guide you and to the endomarch.org for the other sessions, and thank you. And Dr. Farr Nezhat is going to go ahead and take over for the rest of the program. I will meet you again at the end of the session to let you know about the next month and the coming month, what other programs we are having in preparing it for you. Thank you again, and we appreciate all of your support of the patients with endometriosis everywhere. Thank you.
Thank you
Farr
very
Nezhat.
much, Camran. Good morning, good evening, or good afternoon, no matter which part of the world you are. It is a pleasure to be the director of this session, and I would like first to thank our panel for today. Two of our patients. First one is Marketa Janska, and the second one is Jennifer Peralta, that they will share with you or with us the journey about endometriosis. Then we have Dr. Sheeva Talebian, board certified reproductive endocrinologist and fertility in New York City. And then we have Dr. Daniel Seidman, known reproductive endocrinologist and infertility in Israel, to share with us his opinion, and we discuss about each topic. Then we have Dr. Sheeva Talebian, one of my fellows that share with you her opinion about her experiences, and Dr. Marketa Janska and Dr. Shruti Agrawala, Dr. Camran Nezhat fellow. Briefly about ovarian endometrioma or endometriosis or chocolate cyst or hemorrhagic cyst. I give you a little bit background before we go to the discussion about this topic. Briefly, endometriosis could be superficial in the peritoneum, almost any part of the body, or it is called infiltrative, which is deep invasive to the tissue, or on the ovaries, could be, again, superficial or infiltrative. But one specific thing about the ovary is that the endometriosis on the ovaries could cause a cyst that almost rarely we could see any other parts of the body. So, and the importance about this, the endometriosis on the ovary, is that besides causing other issues like pain, infertility that you could see with peritoneal endometriosis, could cause effect on the function of the ovaries and affects the hormonal production of the ovaries. Also, the issue that sometimes could become cancerous, that I will discuss it myself later. So the issue of the removing the endometrioma, when to remove it, and how to remove it is the subject of the discussion between infertility specialists, gynecological oncologists, and other physicians. That is briefly about this topic. As I mentioned, this condition could cause infertility, could cause pain, or sometimes the patient could not have any symptoms, and incidentally was found during the regular gynecological examination or for evaluation of other conditions. So after this brief introduction, I would like to start with one of our patients, Marketa Janska. She was one of Dr. Camran Nezhat's patient, and share her journey with us and her experiences.
Yes, hello. It's nice to see everyone. Thank you. My name is Marketa Janska, and I'm a patient of Dr. Nezhat. My surgery took place around 3 years ago, and now I have a 2-year-old little baby girl sitting, playing with the little train wheel. Yes, honey? 1 second. Okay. I was trying to get pregnant in 2015, for about 3 years, and then I couldn't get pregnant. We had to have help with the fertility doctor. I did IVF, but before my transfer, I had this weird feeling that I didn't trust my uterus, and I asked for an additional test, and we did a biopsy of my uterus, and it came back with the endometriosis cells. I was advised by my fertility doctor to reach out to Dr. Nezhat and schedule a surgery, and that happened 2 months later. I was very fortunate that it was fast, that I was able to come in, get it done, and next month I conceived naturally, and yeah, now we have a 2-year-old daughter. So this is a short, I guess the short version, but that's how it all happened. My period since the surgery has been mild. I'm still nursing. I think it's the result of coronavirus. So we're still nursing, and my periods has been very mild and no pain whatsoever. So yeah, I'm very, very happy and very fortunate that I was able to get with Dr. Nezhat. So thank you.
Marketa, thank you very much. And we would like to thank your husband, Ryan. So thank you for participation of the Stella, your beautiful daughter.
Thank you very much.
We appreciate, if you don't mind, hang around later on, if in case any of the audience or have any question, or I may ask you a question myself later. Thank you very much again.
Thank you.
So we go to the next speaker, Dr. Sheeva Talebian. As I mentioned, the effect of the endometrioma on the ovarian function is the subject of the debate about when to remove it, how to remove it before the IVF, after IVF. And I have had the pleasure of working with Dr. Talebian for past several years, and numerous of the patients that they have gotten pregnant, and I really appreciate to be part of our team. Dr. Talebian, as I mentioned, she is a board certified reproductive endocrinologist, well known in the New York area, and we get referral from different parts of the even country to come to see her. Sheeva, please go ahead. And
okay, great. Just everyone can hear me. Can you hear me okay?
Yes.
Yeah. Okay, good. Hi, I'm Dr. Sheeva Talebian, and I am a fertility specialist at CCRM New York in Manhattan. And as Dr. Nezhat said, I think increasingly I've been collaborating quite a bit with him over the past several years. And I've been practicing as a fertility doctor since 2008, and did my fellowship training before then. And I think that, you know, just anecdotally and personally in my career, I think that we are learning so much more about endometriosis. And I strongly believe endometriosis is way more prevalent than we originally thought. I have been seeing and noticing quite a bit in my patient population, especially those that are really under the age of 40 and even under the age of 35. There's a very high presence of endometriosis in these patients. As well as I think endometriosis is the culprit of a lot of what we call unexplained infertility. So 20 to 30% of patients are diagnosed with unexplained infertility. And I really think that if we did surgery on those patients, many would have endometriosis. So just to briefly talk a little bit, we have patients who come in and I do an ultrasound and I say, wow, I think, you know, you have an endometrioma there. You see the endometriosis on the ovary. And I think the question as to, do they go straight to surgery? Do they do fertility treatment? It's not a straightforward answer. I think it depends on the patient's history, her age, the size of the endometrioma, the appearance of that endometrioma. Is there anything concerning about it? For sure, if there's anything at all radiographically that looks concerning, that those patients would go straight to surgery before any fertility treatment. However, in some of our patients who we see the endometrioma, it's not very big, it doesn't have any concerning features on the sonogram, and they have very good ovarian reserve, meaning a good follicle count. Oftentimes we'll counsel them, especially if they've had infertility for quite a bit, to maybe do some IVF, obtain some embryos, chromosomally screen those embryos, freeze those embryos. And then when we feel that we have enough embryos frozen, to go and do the surgery and really clean it all out and then do the implantation. And we're finding that, you know, a high rate of success when we really clean up that endometriosis before they do the implantation. So, you know, and then there's other patients like Marketa where they present with this unexplained infertility, they do IVF, they make good embryos, and perhaps they even transfer a couple and they're not getting pregnant. Or as time goes on, we highly suspect that maybe there is endometriosis, and there are these biopsies that we can do where we're checking for the different markers of endometriosis and then potentially doing surgery before they do the implants. So I will say that more and more I am sending my patients, as Dr. Nezhat can tell you, to do surgery at some point. Again, if they are doing IVF and perhaps not making good embryos, or embryo quality is poor, sometimes I'll refer in that scenario, versus getting the embryos, freezing the embryos, and then doing a really good endometriosis surgery before the implantation.
Sure, thank you very much. One of the issues that some reproductive endocrinologists arguing, or is debatable, is the size of the endometrioma, and also if the patient has pain or not. What are your thoughts about that?
Yeah, absolutely. So when patients come in and it's, you know, a pretty small endometrioma, maybe less than 4 centimeters, they have, you know, they're not having significant pain that's influencing their lifestyle, then, you know, I think in those cases, then, and again, that the ultrasound shows this endometrioma not to have any concerning features, I think in those cases, perhaps they might pursue the fertility treatment first. But most certainly, if they're having significant pain, if it's sizable, you know, definitely over 4 or 5 centimeters, I much prefer that get it taken care of before the pregnancy is established, because obviously there's concerns that, you know, the estrogen in the first trimester, then the pregnancy, these endometriomas can grow, they can change their features on the ultrasound and look a little more concerning. And then, you know, the worst case scenario to me would be that endometrioma rupturing or becoming symptomatic during the pregnancy, and now this person needing emergency surgery when we could have taken care of it in a much more controlled manner.
Thank you very much, Sheeva. As you mentioned, I just want to emphasize what Dr. Talebian said, because I'm sure we may have some physicians listening to this webinar, that they look at the characteristic of the endometrioma, because I have had endometrioma of 3 centimeters, and it had a nodule inside of it that turned out to be a cancer. And the patient actually was 29 years old. So, you know, although the size is important, the bigger the size is,
right,
more problematic. But besides the size, also the characteristic of endometrioma is important, that when the ultrasound performed and there is a nodule inside of the endometrioma, and then you have to be sure this is not some sort of cancer. And as sometimes we order MRI to differentiate between the blood clots and a real nodule that has to be operated. We should not ignore this issue. Thank you very much, Dr. Talebian.
Thank
So,
you.
now, sure, if you don't mind, hang around. So I'm sure we'll come back later on to address other issues. Thank you very much, Sheeva.
Absolutely. I'll be here.
Yeah, thank you very much. So now we go with our next patient, Miss Jennifer Peralta. This is the Camran Nezhat patient, and also she shared with us her experiences. Jennifer?
Hi, everyone. Can you hear me okay?
Yes, thank you very much.
Okay, thank you for having me. So I'm 21 and I've been dealing with endometriosis since I was 9 years old, although I wasn't diagnosed when I was 9. I started my period when I was 9 years old, and ever since then, it has been a struggle. I have had missed opportunities and missed work. I have spent many days, nights, and like a lot of hospital visits, just to be told nothing was wrong. It was going back and forth between doctors, emergency rooms. We tried everything. I was put on so many different birth controls from about 9 years old when I started my period to, I want to say like 13 or 14 years, I tried many different birth controls to control my periods, so heavy periods that lasted weeks and made me spend my nights in the hospital in crazy pain. No one believed me. Doctors would be like, oh, that, like, that's what a period is. That's what being a girl means, like periods. This is, this is the life. But I believed otherwise. And so did my parents. So fast forward to when I was 16, we tried birth controls all the way till then. We're like, you know what? This, like, something's not right. So I go to Stanford at age 16 and found an OBGYN in which she did so many, like, countless ultrasounds, blood works. I described like my pelvic pain, my body pain, worst cramps ever. Like, I would describe it to people and be like, it feels like I'm in birth. I've never had a baby, but I'm pretty sure the pain is close. So I had bad leg pain, back pain, pelvic pain, like to go to the bathroom, the pain was just unbearable. So she had said, you know what, let's schedule surgery and like see what it is. And my first surgery with her, she had took me in and she had said she found endometriosis, but she did not get it all. So I was just thankful to have an answer at that age. At 16, I knew nothing about it. I wish I would have had more support, knew I wasn't alone, and be more educated on what endometriosis even was. Again, I was a little girl with no idea, but I knew that I was in lots of pain. So at 16, my first ever surgery to find out I had endometriosis, and I would say it helped for a little. About a year ago, at age 20, I sat at my job and I said, oh my gosh, I'm in the worst pain I've ever been. It was back to back missing work again, like coming home and just being in pain, laying in bed, sitting in my car, just like, should I go to the emergency room? Should I not? I went to the emergency room a lot last year. And I'm like, I'm pretty sure my appendix burst, but that was not the case. They did a blood work again, like, nothing's wrong, you're fine. Here's a shot to like make you feel better and go home. So I sat on my computer one day and I'm like, I'm losing hope. Like, this is all back again. I sat and searched up the best endometriosis doctor in the world with no hope that I would find Dr. Camran Nezhat, literally 2 hours from my house. So that was like amazing. And I started reading his page, Dr. Camran Nezhat's website page. And I'm like, wow, this is me. Like, all these symptoms, like, this is what I have. I knew I had endometriosis, but like, my doctor never followed up with me. She was also just an OBGYN. She was not a specialist in endometriosis. So the fact that I found Camran Nezhat, who specializes in endometriosis, and cyst on my ovaries and just everything. From the moment I made an appointment and got in with him, the first thing that he told me was, the pain is not in your head. Like, this is real. Like, you are feeling, like, what you're feeling is real. Like, your emotions are valid. And it was just so nice that I found him, because he believed me and he believed that my pain was real. And 2 months later, I go into surgery with him. And my biggest fear was not being able to have kids. So when I first seen him, I'm like, you know what, like I want to be able to have kids. I'm nervous I'm not going to be able to because I've had endometriosis since I was 9. It's been a journey. So when he did his surgery and I got out, the first thing he told my mom was she had endometriosis everywhere. I removed all of the endometriosis and she does not need to have kids right away. That was like a huge relief off my end because that was my biggest fear. And just to hear that he removed all the endometriosis, it's been about 11 months since my surgery with Dr. Camran Nezhat. And to say the least, he has changed my life. I deal with illness still, but I would say I don't deal with it as heavy as I used to. I feel like I'm living somewhat of a normal life now. And it feels so good just to feel like I feel healed, a healed woman. But seriously, Camran Nezhat has changed my life. And I share my story today to bring awareness to endometriosis in hopes to find a cure and to educate, empower women. And hopefully the next person that goes through this doesn't have to wait 7 to 10 years to be diagnosed like I was. So yeah, thanks for allowing me to share my journey.
Thank you very much, Jennifer, for your deep-hearted experience that you had. And this is not, for us, it is unfortunately, it's not new. Every day we hear the same stories. And that is the reason that we are here. So let me ask you, if you have 2 suggestions for the women in your age or older, younger, you have 2 things to tell them. What do you tell them when you have the pain or experience?
My first one would be to listen to your body because that's what I have learned throughout this journey is to listen to your body. Whatever you're feeling is real. And I know there's doctors that aren't as educated on, yes, they're helpful, but endometriosis is not really known. A lot of OBGYNs don't know a lot about it. So it's like, listen to your body and trust, like painful periods are not normal and having to be in the emergency room in pain is not normal. So trust and listen to your body. And my second suggestion would be, to not let the illness define who you are. So no matter for someone who has endometriosis or thinks you have it, like it's something you have to live with forever, yes, but we are strong, women are strong, and we will roll it, we're good. So that would be my 2 suggestions. Listen to your body and don't let this illness define who you are.
Thank you very much. That is exactly what I was going to ask you is that listen to your body. Don't let people say, oh, that is normal. Your mom had pain. Oh, that every woman has pain every month. The pain is not normal. You have to address it. This is a wrong teaching, understanding that unfortunately has been in the mind of the society and has been passed on generation after generation. And again, thank you very much for saying that unfortunately a lot of physicians are not familiar with this condition, and you take the control of your own health and bring it up to the attention of your physician. And if it is not amenable to your listening, look somewhere else. So thank you very much.
I agree. Thank you for having me.
Of course, thank you very much. If you don't mind, hang around here if in case. So thank you very much.
I will. Thank you.
So as was discussed before, the proper removal of the endometrioma is very important. The goal is that remove it properly while you are avoiding damaging to the ovary. And that it is an art, in my opinion, and science. Why I say it is science? We published several papers and we describe the origin of this large endometrioma is ovulation. that combination of the ovulation cyst, which is called corpus luteum, with endometriosis of the surface of the ovary or endometriosis of the pelvic side wall, they get together. And if the patient is not taking any kind of hormonal suppressive therapy like birth control pills or other hormonal suppressive therapy that prevents ovulation, this corpus luteum gets together with endometriosis of the cortex of the ovary, the surface of the ovary, and cause an endometrioma. And if you understand this way that endometrioma or chocolate cyst is formed, then you know how to prevent it and how to treat it. What do I mean to how to prevent it? That if the patient has endometriosis and has surgery, and if he doesn't want to get pregnant, you put them on hormonal suppressive therapy to prevent ovulation, this patient would not develop another chocolate cyst or endometrioma. And that has been our experiences for many, many years. The next thing is that if the patient want to treat them, if you know about this way that endometrioma is formed, you know how to treat it. Now, I will ask Dr. Charoti Agawala, Dr. Camran Nezhat's fellow, to tell us how do you treat endometrioma?
Good morning. My name is Shruti. I'm one of Dr. Nezhat's fellows. I've been working with Dr. Nezhat for over a year now. I'm a second-year fellow. So on a daily basis, I think on a weekly basis, we treat endometriomas very often. We go into surgery knowing that the patient has endometriomas, or we go into surgery and find that the patient has a small endometrioma or an infiltrated endometrioma that me as a fellow, I'm unable to see, but then Dr. Nezhat is able to see that it is right under the surface of the ovary, and then he's able to excise it. But most of the time, we try to just excise the endometrioma and the cyst capsule without injuring the ovary, because most of our patients are young women who are looking to help preserve their fertility. So Dr. Nezhat has been paramount in teaching us as general OBGYNs how to excise the endometrioma and the complete cyst capsule without injuring the ovary. Because I think as a resident, when we would see really large endometriomas that were basically encompassing the whole ovary, our attendings would mainly take the whole ovary. So over the past year, we have seen some pretty hard cases where he was able to teach us how to properly and safely excise the endometrioma and the capsule without injuring the ovary. So it's been a great learning experience with him in the past year to be able to see type 1 endometriomas, type 2 endometriomas, and also how to go about taking out the adhesions and treating the endometriomas and helping to save the ovary, the healthy ovarian tissue as much as possible.
Thank you very much. If you want to give a tip to some physicians that they are watching this program, if they want to remove the endometrioma as a surgeon to avoid damaging the ovary, what do you tell them? I mean, you are a young physician. How do you tell them to do that?
So I'll tell what went through my mind when I started the fellowship as, you know, a resident who had just finished general OBGYN. And after a year with Dr. Nezhat's fellow, what goes through my mind now? So before, when I first started and I would see large endometriomas with bowel adhesions coming up to the ovary where you couldn't even see the ovary, all you saw was, you know, the whole endometrioma in the whole pelvis. In my mind, I used to think, I have to take the ovary is not gonna survive. So the first thing that went through my mind is a little bit of freaking out to be like, you know, I just gotta take the ovary. Over the year as I have gone by, my thought process now, when I look at bad cases, is I try to think what Dr. Nezhat is thinking. And instead of thinking that I need to take the ovary, I start thinking how he's going to plan to systematically, slowly, carefully take down the adhesions, find the ovary, plan how he's going to excise it, and then goes about to do it. So I would say my one tip is don't freak out and jump to the conclusion that that ovary needs to be taken out because there's no way to save it. If you just do it systematically and do it one at a time and do it carefully and slowly and take down the adhesions and look at your whole picture, I think you'll be able to plan a better excision surgery rather than the patient just losing the ovary.
Thank you very much. Thank you very much for this important step. So I just want to share with you, because I'm a GYN oncologist and also a background of infertility and endometriosis specialist. And it is not unusual that patient has endometrioma and chocolate cyst. By the way, the reason we call it chocolate cyst, because this endometrioma, the fluid inside of it is old blood, and the color is old blood, is dark like chocolate. So that is the reason we call it chocolate cyst. So just want to just explain that one. And then, unfortunately, one of the tests that it is done frequently for ovarian cysts, or it is called CA125, and it is frequently elevated. And the combination of the elevated CA125 and the cyst, people think it's cancer and they refer them to GYN oncologist. And a lot of my colleagues, unfortunately, although they are excellent surgeons, they may not familiar with the pathophysiology and the way that endometrioma is formed, and maybe easier for them to remove the tube and the ovaries than to save the ovaries. So when I said dealing with endometrioma is a combination of the science and art, is that you should know why endometrioma is formed. Frequently is the scar adhesions or scar tissue is involved, especially on the left side is attaches to the bowel. A lot of physicians are afraid to tackle this cyst because they're afraid to the bowel, and rightfully that is correct. That is, they should stop. So it is better to stop and refer the patient to proper surgeon that doing haphazard surgery, removing part of the cyst or damaging the bowel. So that is important, that as a physician, as a patient, if you are diagnosed to have endometrioma and your physician tells you have endometrioma and he or she decides to operate or decides to refer you to somebody, you're asked the question, who is this person? What is the experiences? And look for that right person, because that is very important. You don't want, as Dr. Aguilar said, to remove the tube and the ovaries. Also, you don't want to get to the complication. So after this discussion, we go to the next speaker, Dr. Daniel Seidman, a great friend of ours for many years, famous internationally for his pioneering work. He has more than 250 peer-reviewed papers, chapters, and to talk to us about egg freezing, role of egg freezing, embryo freezing in women with endometrioma, endometriosis. Danny, thank you very much. Good to see you after a long time.
Thank you. I hope you can hear me well. And I'd like to thank the Nezhat brothers who not only trained me well, but also really the #1 experts, or the #1 to 3 experts of endometriosis. And I think they're doing a great job of bringing news on endometriosis. Personally, I'm both a very active IVF specialist, and also I'm a co-founder of a company called AIVF, where we're trying to bring artificial intelligence for the help of IVF and improving women's health, and we really have some very exciting developments. I'm sure we'll be able to talk about this another day. Regarding egg freezing, it's an extremely important subject for endometriosis. Actually, the Israeli government recognized it as such an important issue that they're actually completely funding egg freezing for patients in Israel. This just comes to show you how important it is. We know that there are two major factors that affect future fertility. One is age, and we know that from the age of 35, fertility starts declining slowly, from the age of 40, declining quickly, and also any damage inflicted on the ovaries. Now, this can be directly inflicted by the endometriosis itself, the lesions or the endometriomas, and also unfortunately, by surgery. This is also why it's so important to go to an expert surgeon when you're treating endometriosis, because when highly expert surgeons like the Nezhats operate, the likelihood of future damage to the ovaries, which will affect your entire life, is much smaller. So currently, what we suggest is if you've reached the age of 30 to 35 and you haven't yet completed your fertility plans, you should at least consider freezing eggs. If you had multiple surgeries, or if you are planning future surgery, this is even more important to you. Now, two things you have to remember. One, you already mentioned age. So the earlier you freeze your eggs, the better. And currently, we recommend freezing around not after 35 or 37, when fertility starts to decline significantly. And again, if any surgery is planned, this would be a good time to think about first freezing eggs and then doing the egg freezing. We know for sure that after prolonged endometriosis and after repeated surgery, there's a big decline in fertility. We always tell our patients, go check your fertility status, what we call the ovarian reserve, which actually means how many eggs do I still have in my ovaries. And you can do this by two major ways. One is ultrasound, where we call it antral follicle count. We count the small follicles at the end of the period. Or you could do an MH serum test, which is a simple blood test, not too expensive and highly predictive about the future. It doesn't tell you if you're going to get pregnant now or not, but it's going to tell you, should I be quick in freezing my eggs? We usually recommend freezing at least 20 eggs, because the younger you freeze and the greater number of eggs you freeze, the higher your chances. Again, you shouldn't get obsessive and start freezing hundreds of eggs, but if you are around 30 to 35, we'd recommend freezing at least 20 eggs. And if you're over 40, if you manage to freeze 40 eggs, you'll be in an even better position. And we estimate that if you're around 36, you probably need 10 eggs to have a 50% chance of having a child, or maybe double the number, 20 eggs for an over 90% chance. But if you're 39, you probably need about 16 to 20 eggs. So age is a major factor. And of course, there's a matter of luck, because some patients freeze 20 eggs, and this is enough for them. I just had a patient who froze her eggs in my clinic when she was 40, met her boyfriend when she was 45. They decided to have a child together when she was 48. We defrosted only 3 eggs, and she just delivered a baby. And we have multiple examples like that, where even just 2-3 eggs. I had another patient with 39 frozen eggs, and we again defrosted 3 eggs, and she delivered twin girls. So this technology does work, and you should definitely consider it if you haven't completed your family size. I mean, you can do it even if you have 1 or 2 children and you know for certain that you want another child. Now, cost is always an issue, but actually the big cost when you freeze eggs is sometimes how much the clinic charges for saving your eggs per year. Now, if you're very young and you start freezing your eggs at a very young age, this might be, should be calculated, how many years of freezing. And when they tell you how much they charge for the egg freezing, always ask them how much I will be paying for the storage, because sometimes that's where they're making their money, okay? And it's a very competitive market, which is good news, because you can shop around and you can ask clinics, and it's not a technique that you need huge experience. Unlike the surgery that we mentioned, with only a few masters of the trade, in egg freezing, any good IVF specialist can do this, and technically it's not difficult to freeze eggs. So it's definitely something you should be considering if you haven't completed your family. And again, especially you should consider this if you're doing surgery. Another interesting tip that I could mention, some patients are undergoing anyway surgery for endometriosis, and if you're very young, this could be also an opportunity to freeze fragments of the ovarian cortex, which we know are very rich with the follicles. You could freeze them and then you could put them back years later. And sometimes, if you're anyway undergoing laparoscopic surgery, you could consider this. Again, this is something that not every hospital knows how to freeze ovarian fragments, but if they have a big oncology service, or they can also ship it out. I mean, any doctor can freeze these fragments, and if he gets the right instructions, and defrost them and freeze them and store them in a big fertility center. So these are my main points, and I hope I was instructed.
Danny, thank you very much. That was the excellent guidance, excellent information. And thank you very much for mentioning about the ovarian tissue freezing. I know that maybe in Israel is more common than in United States. Actually, we have these opportunities in one of our hospitals, actually both of the hospitals, in Cornell Hospital and also in NYU Winthrop, to egg freezing, and I work with this, our colleagues frequently, because of some of the patients have cancer. So it is easier for us to guide the patient for egg freezing. Regarding the endometrioma, which patient do you recommend to have egg freezing? I mean, younger patient, when they go for surgery, you recommend them to have egg freezing, or because the cost is an issue?
First, I think bilateral ovarian endometrioma is a big, important point. I mean, if it's a patient that's undergoing surgery for the first time and only on one side, only one ovary might be damaged, I think they should be less worried. But if this is repeat surgery, especially surgery that was done on both ovaries, I think these patients should, at any age, consider freezing eggs. And of course, the older the age, once they reach 35, 36, where age plays a major factor in the ovarian reserve, they should consider it. But bilateral surgery is something that should raise a warning sign. Are they damaging my ovaries, and should I freeze eggs? And again, always think, before you do surgery, it's not just relief of pain, it's also damage inflicted. That's why it's so important to do this with a highly trained surgeon that knows not to burn up your ovaries. And I've seen some bad surgeries, unfortunately, and especially the outcomes. And it's amazing what the difference is if you know really to dissect the endometrioma out with minimal damage, thinking that this 18-year-old girl still needs ovaries for the next 20 years. So this is very important.
Thank you very much, Danny. I appreciate that one. So I know I like to ask Dr. Shadi Siraji that she is my fellow and has been working with me for past more than a year, to share with us about her experiences about dealing with endometriosis and endometrioma. Dr. Siraji.
Hi, everyone. Before joining Dr. Nezhat, during my residency training, I had learned about endometriosis, and at the time I thought that my knowledge was adequate enough. Later I know, a year and a half later, I realized how superficial that knowledge was. Under care of Dr. Nezhat and his tutelage, I've learned so much, and it broadened my knowledge about endometriosis. I was not aware of the effect of endometriosis, the extent of it, and how the patients suffer from the endometriosis. I was not aware of the connection of the endometriosis, the extent of it on infertility. I was also not aware of the malignant transformation of the endometriosis. The first time that I heard about it was when I started working with Dr. Nezhat, and which it taught me how important it is to
I think, Shadi, unfortunately, your camera got frozen. Okay, I take over here, finish what Dr. Shadi Saraja was saying. So actually, it's a good time that I address this issue of malignant transformation of the endometriosis. And briefly, the same way the lining of the uterus, called endometrium, could become malignant and could develop different types of the histology of cancer. The endometriosis tissue, which is similar to the lining of the uterus, also could become, unfortunately, malignant or become cancerous. And briefly, the reason behind it is combination of the high level of the estrogen and also inflammation. Endometriosis is an inflammatory process, and the high level of the estrogen on the ovary or even on the endometriosis implant could cause this transformation. So fortunately, not all the patients with endometriosis, the cyst become cancerous, but unfortunately, this possibility exists. Women with endometriosis, the chance of developing cancer is twice as compared to general population. So it is not very high. However, you have to know about it. As I said earlier, if the patient has chocolate cyst, endometrioma, and we decide not to operate on it, we believe any endometrioma has to be operated on no matter how small it is. You operate on it because endometrioma rarely is by itself. Always there is endometriosis somewhere else. And because we don't know if the endometriosis could cause pain or not, and we believe the earlier you remove the endometriosis, you have prevented this endometriosis getting worse. So what our philosophy is that even the small endometrioma has to be operated on and killing the endometriosis, other parts of the pelvis. If the patient is not ready to get pregnant, put them on hormonal suppressive therapy and follow them carefully. This is the way that we recommend. This is our policy, similar to patients with cancer, that we could follow them closely, because unfortunately cancer could come back. Endometriosis frequently is a recurring condition. So we believe you have to follow the patient carefully. If doesn't want to get pregnant, put them on suppressive therapy and follow them. And if the patient has any kind of symptom, even if they have gone to menopause and had history of endometriosis, and now comes to you and she is complaining of the pain or unusual condition, endometriosis should be in your back of your mind. Unfortunately, endometriosis, any part of the body, it could become malignant. We have seen it. Endometriosis of the skin become cancerous. On the bowel, frequently could become malignant. On the bladder, we have reported it. even in the liver, in the lung, or could become malignant. As I said, the possibility is low, but unfortunately the possibility exists. And that's one that I wanted to keep in mind to know about it. So we have only a few more minutes. I just want to ask Dr. Talebian, any last thought, Dr. Talebian? What do you think about the egg freezing and tissue freezing that Dr. Seidman was saying?
Yeah, hi, sorry. Absolutely, definitely in any of these women with known endometriosis, and again, as we say, it's a highly enigmatic disease, right? There's people with severe endometriosis who don't have infertility, but the assumption should be that this endometriosis will at some point potentially negatively impact the egg quality and their chances of getting pregnant in the future. So we are absolutely big advocates of egg freezing, potentially embryo freezing, depending on their exact specific history. And, again, we have, many, many women coming in to freeze their eggs, pre-surgery, sometimes post-surgery, if they didn't know they had endometriosis until they did the surgery with you. But I agree with, all of the discussion today is highly, highly relevant. And as I said, just even me in my own career, I think we are learning so much more about endometriosis, and it's highly critical, especially, for those of us who have daughters and young women, in our lives, not to ignore a lot of the symptoms that they have. So I really appreciate the patient stories as well.
Thank you very much, Dr. Talebian. And now I'd like to ask Dr. Tavallaei, a fellow of Dr. Camran Nezhat, to share with us her experiences. Dr. Tavallaei.
Hi, hello.
Good.
Hi, so yeah, I joined Dr. Nezhat's team almost like 2-3 months ago. I did 2 years of pathology residency before at Stanford before I do my OBGYN training. And it's actually been really fun because like 4 years ago, I used to get all the specimens from Dr. Nezhat's group and look at them under the microscope to find the endometriosis, which would be pretty amazing for us because we could basically just compare the specimens that we got from like different doctors. And I see Dr. Nezhat when he's talking to the patients and counseling them about, it all depends on the surgeon and the experience of the surgeon to see the tissue and be able to do the endometriosis surgical management in the best way possible. Because yes, we used to get all the specimens from different doctors, and you see based on their experiences, you actually see the endometriosis tissue on the smallest tissue that you get. And now that I'm in this side and I'm in the OR with him, he points at some lesions that all of the new fellows and probably like the old fellows as well just look and say, oh, this looks like normal tissue. However, because Dr. Nezhat is pretty experienced, he can see the lesions and just like excise them, and we send it to pathology and the results come back and endometriosis, which is pretty exciting for me to be on both sides and see the surgical and also like the pathological findings of the endometriosis. And I think it's very, very important for everyone who's going under surgery to make sure that the surgeons are pretty experienced in endometriosis. As Dr. Saraji was saying, during our residency, we get a lot of training. It's just like an OBGYN residency. And there's like a lot of different things to cover during the residency. And endometriosis is just like a very small portion of it, which I think it's really good that the generalist OBGYN can diagnose the patients and just refer them to people who are a lot more experienced and are specialists in endometriosis to be able to follow them and help them both in terms of pain management and infertility.
Thank you very much, Dr. Tavallaei. Camran, can you see me?
Yes, I can see you. Yes.
Thank you, man. For some reason, my screen turn off. So I'd like to thank everybody, Marketa, Jennifer, Dr. Talebian, Dr. Seidman, Dr. Tavalai, Dr. Siraji, for your excellent points. Now I turn it over to Dr. Camran Nezhat to finish the session. Thank you very much, everybody, again. Have a nice weekend.
Well, thank you very much, Dr. Farr Nezhat and his wonderful guest for a very enlightening and educational session regarding management and treatment of ovarian cysts, endometriomas, and egg freezing, infertility, and pain. I thank Dr. Farr Nezhat, his guests, Dr. Talebian, and Dr. Seidman, Marketa, and also Estella and Ryan and Jennifer. Also, I'd like to thank Dr. Siraji, Dr. Tavalai, and Dr. Shruti Agrawal for their participation and for assisting to raise the level of awareness about endometriosis. And most importantly, we thank all of you, the viewers who are interested to change the status quo for endometriosis, finding a cure for endometriosis, and end the dynasty of endometriosis on the lives of patients with endometriosis and their families. We don't want to see any more young women having hysterectomy, removing their tubes and the ovaries removed at a very young age, and unfortunately still we see that sometimes. Sometimes there is absolutely no choice. I do understand that, but nowadays there are many choices. Next month series are going to be about issues that has for years confronted couples who have tried to have children and they are told everything is normal. All of their tests are all normal. They have no pain. Husband is okay. The wife is okay. The partner is okay. All the tests are normal. They have had all kinds of tests or have done all kinds of fertility treatment, failed IVF, and they don't get pregnant. Often these patients have endometriosis, and we have wonderful guest speakers that they are going to address with patients about all of this. Meanwhile, if you are interested to learn more about endometriosis, go to endomarch.org. If you go to endomarch.org, there are the webinars, and the webinars you can find your session of interest. Also, if you think you or somebody may have endometriosis, there is an app that it is free around the world. It is called Nezhat Endometriosis Advisor. It is on endomarch.org. You can find and download that. We thank you very much again for your attention. And until the next month, forward we go and have a great time. Bye-bye.
Thank you.